You've arrived at the Mental Health Spotlight podcast with therapist Kais. Today's guest is Dr. Ann Kubal, a licensed clinical psychologist with a vast background in mental health and eating disorder treatment, along with training and educating providers of care in the community about eating disorders. Her resume is as long as it is impressive. A few highlights include earning her master's degree and PhD from Northwestern University and Michigan State University, respectively. Most recently, and for many years, she served a vital role at eating recovery centers and Pathlight Mood and Anxiety Centers as the director of clinical training. A member of the American Psychological Association and certified eating disorder specialist and supervisor through the International Association of Eating Disorder Professionals. She holds several clinical and educator roles at Northwestern University and teaches at Northern Illinois U. She is currently dedicating her time to private practice and a steering committee to establish a new eating disorder division within the American Psychological Association. Ann comes to this interview ready to educate with confidence, passion, and sometimes in-your-face lessons for both professionals and persons and families affected by eating disorders. It is a conversation I have longed to have since I first chatted with her and walked away with a stack of Post-it notes and pieces of wisdom I wanted to borrow for my own practice. A very needed, honest, humorous, and fiercely passionate champion of the eating disorder recovery path. Welcome, Ann. I have been, stalking you for quite a while. Yeah, I think I've been asking because you are so busy but such an asset to this community. So I'm thankful that I have some time to talk with you today. So welcome.
Thank you for having me.
Absolutely. We've worked together with teaming up on a client for a while, but I don't really know that much about your professional history. Just talking to you amazed me. Can you tell us a little bit about where you come from and what you do in this field?
Yeah, actually, I always tell people just because I think maybe it's part of my story. In a former life, I was a special ed teacher and I taught middle school. I worked with kids with social and emotional disorders, what we called it back then, and learning disabilities. And I knew I wanted to be a teacher and a psychologist. So I spent a lot of my early work working with children, adolescents, and families. And I developed a clinical fascination. I did a lot of crisis work with kids who are wards of the state during my master's program and ended up working with a lot of what we now call non-suicidal self-injury. And so I really had a strong clinical interest in non-suicidal self-injury that carried into my PhD work, but also had the opportunity to work in the College Counseling Center at Michigan State. And we were asked to choose a specialization that year. It just happened to be that the director of the counseling center and my training director were eating disorder specialists. There's a really high co-occurrence between eating disorders and an SSI. And that is how I came to the start of my journey as an eating disorder specialist.
It's on accident? Is that fair to say?
A little bit of a roundabout way that I landed in eating disorders, but it makes sense. Researchers have always said that in SSI and eating disorders, it's just two different manifestations of that same underlying deficit in self-care. And I always think about it as just two different ways that people learn to express themselves through their body rather than using their voice or using their words. So I still see there's a strong connection between those maladaptive coping behaviors. So
it does. And what you just said was already so awesome. I'm like, okay, there's our tagline. We're 3 minutes in? I'm like, wow, that was a beautiful way to describe not only disordered eating, but also this other aspect.
For me, it's loss of voice. I always feel like one of the fundamental goals of doing eating disorders work is helping people find their voice and use their voice.
Excellent.
If they have their voice, then to use it louder.
Exactly. So people can hear it.
Yeah.
Trust that voice. You took this farther into working in facilities as well, right? It's how I think I came across you.
I did. I ran the eating disorders treatment team at Northern Illinois University and worked in their counseling center and did a lot of training for about 6 years. And throughout it, I had started teaching a graduate course on the treatment of eating disorders. And then I had done my postdoc at Northwestern University, again, specializing in eating disorders. And during that time, a new treatment center in Chicago opened. At the time, it was Insight Behavioral Health, brand new eating disorders IOP program. We just didn't have them in the city of Chicago at that time. So I moonlighted during my postdoc. So when I was ready for a change after being at NIU for 6 years, I went back to Insight. I loved higher level of care work. I loved being able to intervene when people were kind of in the acute stages of an eating disorder and really struggling. Eventually, Insight Behavioral Health partnered with Eating Recovery Center, but I stayed there 11 years. I was the director of clinical training. I ran our practicum, internship, and postdoctoral fellowship program, and my clinical work really focused on eating disorders. I started a small private practice in 2019, and so did that on the side to be able to continue some long-term work. And then just this past June, took a big leap of faith. And after 11 years, I left higher level of care work and am now fully in private practice.
And I've gotten to see some of that transition because I met you through ERC and now you are private practice.
Yeah, you've been there for part of the journey.
Yeah, you made an interesting connection there, at least in my head, is when you work in higher level of care, you get people for a specific period of time, and that acuity that you were so drawn to in outpatient, this opportunity, you can see people indefinitely. Did you want that? Is that the benefit?
I've been lucky because I was lucky enough in my role as director that I could continue some outpatient work quite a bit longer than we are offering it as kind of a standard part of our treatment. I've had the absolute privilege of being able to do long-term work while still getting higher level of care work. I have a patient that I have worked with for 15 years, and she actually came with me to ERC, and I see her outpatient. That's what it felt like. And I do think that was part of my concern about leaving higher level of care. I love the long-term outpatient work. I love just the privilege of being able to see people reach recovery and stick it. Whereas at a higher level of care, you're kind of coming in to the point where people are in acute crisis often. I used to tell my trainees, it's you plant the seeds, but you don't always get to watch the garden grow.
Yes. I love that.
And it's a very important piece of eating disorder work. It's just needed work and it's important work, but it's a different kind of work. I love being a part of people's recovery journey in different ways.
So your perspective is broad. You have so many different angles, which is why I love having you here. I love the planting of seeds. Being on the outpatient side, when someone leaves higher level of care, I don't think they're anywhere near done. I think just like you said, that they have gotten that foundation and now we have to grow it for what could be a really long time. This isn't a short process, right?
Yeah. Recovery isn't linear, right? We all know that. Every therapist, eating disorder therapist I know, and patients will tell you too that they have that picture of what the expectations of recovery are, this nice linear line, and then what the reality, which is messy and not pretty and difficult. But just because people aren't to the point where they feel like they're in recovery doesn't mean that growth isn't happening.
I love that. And you see that at all levels. You see where it begins. And then when you stay with someone a long time, you do see it kind of blossom, to use your metaphor again.
Yeah. My favorite part of it is that sometimes, oh boy, we don't always define recovery very well. In a lot of ways, it's really individual. And some people kind of equate it to addictions where people are always in recovery. I think the fascinating part of being at this point in my career is I have had really the honor and privilege of seeing people who didn't think they'd ever get to the point where they felt like they were in recovery, quote unquote, get there to the point where they felt like they were in recovery. And then I have also seen people who got into the point where they feel truly recovered. And I don't think one is better or worse than the other. There may be people who are in recovery their entire life. There are other people who may feel like they get to the point where they're recovered. And I think there's a lot of people who get to the point where they feel like they're in recovery and then are surprised to feel like they have truly recovered.
And you brought up a hot topic, which is, can you recover? So I'm hearing from you that there is a recovery. It's out there. It just maybe doesn't look like a traditional recovery that we think of.
I really think it's individual. Back in the day when our field was dominated by old white men who smoked cigars.
Wait, I smoke cigars. Is that bad?
No, that's the picture of what our field used to be, right?
True story.
Little bit of a Freud joke in there, and not to knock on Freud. He was right about a lot of things, wrong about a few others, but
you should come in at least once during our conversation.
Somewhere around here, I literally have a Tickle Me Freud doll that sat in my office for years. It's a little bit like Tickle Me Elmo, but it's a little Freud doll.
I have Bob Ross, you have Freud. We should make a good team.
long back in the day, they used to say that eating disorders were caused by quote unquote refrigerator mothers, right? These cold, emotionless women who raised children to have eating disorders. And we know that's a bunch of BS.
Right.
We know now that eating disorders are multi-determined or over-determined, and there are a lot of risk factors that are out there, and protective factors can intervene for sure. But, the path to an eating disorder is not identical for all patients, even if there's shared risk factors. So if we know that and we truly believe it, then I think it's fair to accept that the path to recovery isn't identical for all patients either. That just like the path to an eating disorder may look similar but not the same, the path to recovery may not look exactly the same either.
So we don't have to label it. It is an individual experience, and we just take them as far as they can go.
Right. One of my subspecialties is working with therapists. I've been in the field of training for more than 2 decades. Therapists believe in therapy. We believe everyone should be in therapy. It's an occupational hazard. And therapists make great patients. They're also likely to be the ones to tell you that they hate everything you just said. So they also tend to be pretty candid about your therapy skills.
As are some of our clients.
Yes, for sure, too. That's what I love about working in this field. I feel like it requires you to basically take a no approach.
There's myths everywhere, and you've uncovered 3 of them already.
There's so much bullshit, and you have to be willing just to say it and let people be mad at you. I think that's a gift we give some of the patients we work with who often grew up either through their family experiences or through other experiences, learned that they're not allowed to be angry. And sometimes I know as an eating disorder therapist, we're going to say things that piss people off. One of the biggest gifts as a therapist that you can give to the people you're working with is to be able to hold that anger and not be afraid of it, and have enough faith in your relationship that no matter how angry someone gets at you, that you can work it out, you can figure it out.
I love that. I'm thinking of our shared client. When she hears this, she will laugh because I make her angry, but I think you make her more angry. And then I see her in person. So I get where she's holding something. I'm like, are you going to throw that at me? She goes, I would never, but you get so mad. And then we laugh, of course, because that's part of how we do therapy, right?
Yeah. Well, man, I just think sense of humor is one of the best coping skills. Therapy is hard. We're allowed to bring some humor into it. I always tell people there's a difference between making light of a difficult situation and holding a difficult situation lightly.
Beautiful. I'm going to steal that. It's now mine. It's beautiful.
I think it's helpful, right?
Yes.
We were joking before we got on about that same shared patient. I have a incredible talent of opening my mouth and sticking my foot in. I have joked with my trainees over the years that the hardest thing I needed to do as a therapist in training was learn how to harness my inner introvert, because most times my mouth works about 3 seconds faster than my brain.
But I can edit later.
Yeah, that is good.
You go for it, Anne. You go.
But I do think that humor and being able, even in dark times, to be able to bring some humor in, and also honor the importance of anger, because boy, does it give us information, and important information, as all our feelings do. But just to be able to figure out what our anger is trying to tell us, and that you don't have to be angry in a big, scary way. You can find your own way to be angry, and that's okay.
Yeah. And to me, anger is a combination of so many emotions. It's almost the reaction to such an amalgam. So to be able to have it be unique and allowed, so important. You mentioned the path being individual and unique for each person. And because you've seen both sides, you've had this nice, rich outpatient practice, and you've also had the higher level of care. How do people know? And I know we have assessments and we know where acuity is, but is there a general way you look at where someone should be? And then I guess tagging on to that is, what have you seen changing over time in how people address the level of care that they need?
Yeah, level of care can be tricky. I mean, I think back to my early days where I'd pull out that chart, American Psychological Association chart of
Right.
levels of care, but people don't fit so nicely into boxes. Ethics in eating disorders, that's a really big topic of interest to me, in part because we don't talk about it. It's actually kind of scary how infrequently we talk about ethics in eating disorder work, especially autonomy and issues of control, because it's often a big piece of how eating disorders develop. And so many of the interventions that we use, especially in higher levels of care treatment, infringe on someone's autonomy, right?
Yes. Yes.
We tell them, I'm sorry, you're on exercise restriction. We tell them what to eat. We tell them when they can go to the bathroom. We tell them when they get a break. I always think back to when I was pregnant the first time, and I had to do that glucose test, gestational diabetes test. And that drink they give you is just the most disgusting thing. I still think about this and laugh. I feel like this was karma just giving me a little kick in the butt, because it was only an hour or two before this that I was sitting with one of my patients saying, take a sip of the boost. I was supplementing them after a meal, but pick it up, take another sip. And as I'm sitting there trying to drink this very disgusting concoction, all I could think in my head was, pick it up, take another sip, pick it up.
You can do hard things. Yeah.
Yeah, right. But it makes me think I'm being a little tangential. Basically, us infringing on autonomy at higher levels of care, and just like the complicated ethics of pushing people to do things that they don't want to do, because in the long run, we think it's going to like increase their autonomy.
Right.
We're infringing on their autonomy in the moment because we feel like the eating disorder has such a grip,
Right.
and we want to increase their autonomy and free them from the eating disorder. But really, when I think about the higher level of care piece, what it comes down to me is around ethics in some ways. See, I wasn't so tangential. I could come back to this.
You came full circle.
Full circle. The ethical piece for me is the person getting enough support at the level of care that they're at to make sufficient progress? If I'm seeing a patient in outpatient level of care, even if I'm seeing them like 2 times a week, there's limits to what we can do in an outpatient level of care. If I don't feel like they are getting enough support, not because they're not trying, not because I'm not trying, but because they need more support in order to make progress, right, then I'm going to send them to a higher level of care, because that's not ethical or fair to them.
Right.
If I'm pushing them to do things and they don't have the sufficient support to do the things I'm asking them to do.
That's a great gauge to use, is, are we getting where we need to go in 1 hour a week, which a lot of times is so limited.
Or even an IOP, which is typically 3 to 5 days a week, 3 hours a day, right? Are you getting enough support? Do you feel supported enough that you can do the very hard things we're asking you to do? Or do you need some more support to be able to do that?
Yeah. Looking at the support. And I love that you draw it into that, the ethics that we as the providers need to make sure we're not just providing care to provide it, that we're thinking about that.
I mean, that's part of my soapbox while I still teach. I've taught a class on the treatment of eating disorders for, I think, around 16 years now that I've taught this class. It's because we don't talk about eating disorders in graduate school.
No.
It's very hard to get training on it. And too often early in my career, I would have patients come to me who were like, I've been in therapy for 3 years and I'm not getting any better. And it's not that they were bad therapists. They just weren't addressing the eating disorder. They were talking about it, but they weren't getting the support they needed, specifically to the eating disorder, in order to get better. And so I do think it's always about, what does this person need? What is it they need to make the progress?
Have you ever had anyone with you, and I guess I'm going on a little bit of tangent there, where you and they both know what is needed and it's agreed on, but they just don't have the capacity? And then do you sit in space with them? And because that's also ethical, right? They're not ready for whatever you think they need to do.
Yeah, for sure. I think of a long-term patient. We could not get her to a healthy weight. And I had worked with her in higher levels of care. And one of my criteria for seeing her at outpatient level of care was this kind of, it wasn't like an ideal weight. It was like what I would consider within a reasonable space of her ideal weight, that we could do some work at outpatient level of care. And the irony is that she was not doing well with another therapist. It just wasn't a click. And I ended up caving and took her on even when she wasn't at that weight. And I'll tell you, she ended up falling in love and getting married and decided she really wanted a baby. And she worked really damn hard and she got there and she has a beautiful baby girl. And it's a lovely example about how wrong I can be. And, and how we have to just not always hold such firm boundaries around this topic, that it is so individualized.
A good job. You draw a line in the sand, but you're flexible, yes, when it doesn't happen. But you're good at saying you're very blunt.
Yeah, well, I mean, we got to get there, right?
Better than I am. I'm going around the corner. You're like, here it is, front door.
But that's a piece of it, right? I say this sometimes when someone isn't there and they're having a trouble getting there, wherever there is. Sometimes that is my motto. When you can't go in the front door, you got to look for a side door or a back door and try to come at it from a different angle.
That's right.
And sometimes you sit in it.
And you acknowledge it. You say, we're sitting here.
Right. I have an awful analogy. This is probably a good time to use the edit button.
Well, you tell me and I'll tell you if I want to edit it.
Eating disorder recovery, first of all, it sucks. And I can give you the tools. I can help you with insight. We can do some problem solving. We can do perspective taking. But the reality is eating disorder recovery sucks, and I can't take away the suck.
Right. So true.
It's not going to be sunshine and rainbows.
It's not.
But the analogy that I sometimes use is that eating recovery is like standing in front of a river of shit. And recovery is on the other side of the river. And the only way to get to recovery, which no one wants to do because it's gross and it's disgusting, and I'm sorry for the visual, but you have to wade through that river of shit. And too often what happens is people are like, I am not going into that river. So they're over on the river's edge. They're looking for someone who will build them a boat, or they're looking to chop down trees to build a raft, or they're trying to find a bridge, or they're taking these long hikes up and down the riverbank looking for some shortcut or some way across, because the idea of wading into that river of shit is just too much. Yet, that is what needs to happen, is that you have to walk through the river of shit to get to the recovery.
And all those other things you mentioned are like the subtle recovery hijacks that are just keeping us in eating disorder.
Right. Or it's the avoidance, right? It's like you're avoiding the river. You're looking for everything you can do, everything possible to avoid the river.
And that is similar in addiction, where you just keep rationalizing, I'll do this, I'll do that. And at the end of the day, none of that is going to work.
You really have to walk through it. You have to sit in it. I remember I've used this so many times over the years. One of my patients that I've worked with for a really long time, we were arguing about going back to PHP, which they had done before, and they didn't want to go back, which is understandable. Nobody wants to go back, but they just absolutely didn't want to go back. They knew the skills, they just couldn't use them. It felt like babysitting to them. And so we argued about it for a while, and they eventually got to the point where they're like, okay, I'm going, fine, I'll go. I have a mantra and I'm going. Like, okay, what's the mantra? And the mantra they came up with is, you have to feel the feels and eat the meals. I say that all the time. There's no avoidance. You have to feel the feels and eat the meals. And that's how you get to recovery.
Those mantras, those statements are the inner voice that keep you going when you can't rationalize. You're not supposed to even try. Just go do it.
It's like pushing yourself to do the things that you don't want to do.
Yeah. Yeah. In the military, they use this all the time. Don't think, just do what we tell you. It's going to suck and just do it. But in that case, you sign up because you actually believe.
I think that's kind of the ethics of eating disorder treatment, right? Like, and that's the way we justify doing things like pushing people to do things that they don't want to do, because we agree on the end result that we want recovery. We just may not always agree on what you have to do to get there.
Right. And I wonder if there are options we just have not discovered as a community yet. We're still so new, I feel like. Do you agree that there's so much more we could learn in disordered eating care?
Oh my gosh. Yeah. I mean, I think about, like, I don't remember the year. What was it? 1687, when the first cases of eating disorders were documented in medical literature. And yet it was the 1980s before people really knew it just wasn't talked about. It wasn't discussed. We're so new as a field. There's so much we don't know. Man, as much as the pandemic was just awful on so many innumerable levels, I do think one of the things it brought forth was telehealth. talk about a new way of doing things, being able to give people access to resources that we didn't have the capability of doing before. So even that and how that's changed the landscape of the work we do. The possibility of doing virtual meal groups that you can sit in your home and still eat food with people and hold yourself accountable. Wireless scales. I have the capacity to not trigger the hell out of people and get their weight while we're still doing telehealth.
That piece of it is fabulous.
Even podcast. How many times do we recommend podcasts?
You mean this?
Yeah.
Yeah.
To keep them focused on recovery and help support their recovery. So there's so much different ways of getting people information, different ways of sharing information, even the ability to do family therapy with telehealth, being able to include family therapy more effectively when people are in different states and still being able to have that experience. It used to be you went to residential treatment or you went to a PHP program and family therapy wasn't really a possibility unless you either did it over the phone, which is less than ideal, or your family flew in or was local. But now we can get everybody on camera and we can do that together.
Yeah. So we're at the advent of not only the changes that has allowed, but I also think with social media, eating disorders are getting a much bigger audience. And hopefully that's going to help with research and education too, and awareness.
We still have a ways to go to move beyond the myths of who gets eating disorders. As professionals, looking at different metrics around body image and what is an ideal weight for people who identify as something other than binary. Looking at all of those pieces, I think we still have a lot to learn.
We do, but we're doing the best we can in the moment. we're still doing good work, right?
Still effective treatment out there. We do know that. I mean, I do think that's one thing we know. We know that treatment can work.
That's right. Because we see it. And you've done it for how many years? I've done it for many years. We know.
I think that's the piece I encourage people. If treatment is not working, it does not mean it won't work. It just means that we need to tweak something. Maybe the program you're in, maybe the treatment you're getting isn't a good fit for you. So maybe we just need to look at what's a better fit. How do we tweak it?
We just keep trying. We keep going until we find something because we believe that something will, and we know it will. Sometimes
I tell people it's the fairy dust, right? We know that therapists are really bad at predicting things specifically, but I also think sometimes, and this happens in other aspects of my life, for most people, I think sometimes you're just not motivated to do something and then something happens. You can't even explain why, but the fairy dust lands and all of a sudden you're willing to do it or you know how to do it and things start clicking. And sometimes what I will say is, I don't know when the fairy dust is coming, but I believe it will get here.
When you're that vulnerable, you have to trust that your professionals are competent and they can get you there.
Yeah, for sure.
Which can be a hard thing. To finish digging at the things that are the myths in the eating disorder world, are there other things that strike you that you'd like to just say, that's not true? I think you leaned into this a little bit with even some of the assumptions we make about who has an eating disorder.
That's a big one.
Sorry.
There are so many myths out there. Maybe one of them, and this probably says something about where I'm at in life. You can develop an eating disorder past the age of 18 or 22.
Yeah.
That oftentimes we're seeing eating disorders pop up later in life.
Do you think when you find that, Anne, is there still signs or cues from early life, or are you seeing authentic, it really never showed itself?
I mean, I think it depends. I think about those huge transitions we go through as individuals. I think about divorce that happens in midlife or later, or people whose children grow up and leave for college, and all of a sudden they kind of lose a sense of where they are in life. Oftentimes the risk factors are there, right? But those risk factors are not really risk factors until there's a stressor and something going on in the environment that acts on those precipitating or more distal risk factors that have been there all along.
Yeah, something mitigates it.
Or that someone's protective factors go away.
So it's not always that something comes in, something goes out.
Sometimes it's something goes away rather than something gets added.
I'm going to ask a tough question because why not, right? Do you think it's the kind of thing that is a predisposition, and if those factors come in place, the mitigating factors or the removal of protective, that you're going to have an eating disorder, or that you're not? Like with AA, that's the belief, right? One drink, your alcoholism will show itself.
I think it's more complicated than that. Part because it's hard to quantify protective factors, hard to quantify. It's much easier to quantify this is an alcoholic drink, this is not an alcoholic drink. I think that's the hard part when we use the analogy to substance abuse, because you can structure your entire life to avoid substances.
You can abstain.
You can abstain. You can avoid bars. You can have a sober support network. It's not a perfect avoidance, but you can do that. You can't structure your life to avoid food.
So it would be hard to recognize whether somebody was going to be at risk or not.
Well, and look, we know we have that there's a strong genetic component. I don't know what exactly the research is showing right now, but I know that pathway from risk to having, for example, anorexia nervosa, there's a strong piece of genetics that come into play. I think there's so many things that come into play that can alter that pathway. I think of my mom, who's an identical twin. Even at 85, there are ways that my mom and my aunt, her twin, are so much alike. And yet there's other ways, because of the different experiences they had, that even though they were born with the same genetics, they're so incredibly different. And the other thing I think about a lot is some of my patients who now have children of their own. I think of one of my patients who I'd worked with for a while. She was doing great. She was in a solid place in recovery, and she came back into treatment, in fact, because she had just turned 30 and was trying to figure out whether she was ready to have kids. Talked with a lot of my patients who get to that place in life that in part they're scared to have kids because they're scared that their child's going to end up with an eating disorder or anxiety or depression. And it's not that clear cut, for one thing. We all get some kind of show of genetic storm.
We all get a helping.
Yeah, we all get a helping of something. Everyone gets something. And part of it is they're discounting those protective factors. And they're discounting some of those things that they don't really have control of. We were talking on the break a little bit. I have two children, 8 and 5. I used to tell people there was nothing was going to surprise me about being a parent. I was a teacher in my former life. I grew up working in day camps. I was director of summer camps. What I was not prepared for is within literally 2 minutes of my second child being born, I was like, oh my God, is this going to be different? What? Just 2 minutes in, I knew that from birth, she was a completely different child than my first one.
Yeah.
Because temperament, which we can't change. Their temperament is a piece of how they interact with their environment, how their genes show up, and how their genes impact that environmental interaction. I don't think we can pretend to know. Early intervention is key. Build up those protective factors. Encourage people to get help with the first sign that something might be going on so that we can intervene early. That's what I tell my patients when they have kiddos. Look, you're worried about your child developing an eating disorder. Well, your parents, no fault to them, doing the best they could with what they knew at the time, they didn't catch on. It took them years to figure it out. You're going to be aware of how your child is interacting with food, and you're going to be on the lookout so that if something does happen, you're going to be there to intervene. And therapy works, treatment works, and we can get in there and we can help.
That's such a great thing to tell someone so that it eases that concern of the unpredictable. And you talked a lot about protective factors, and that's a great angle. We're always talking about risk factors, but you're saying if you pad things with what we know helps from the beginning in any situation, you're going to have a better outcome.
Right.
Anything.
And it's I really think that connection and community are a big piece of it. Having people feel connected, having them feel like they're part of something that's bigger than them.
There's certain things we know that do help.
Having people and fur babies and things in one's life that feel important.
Every time I see my dog, I'm like, you are serotonin and oxytocin right here, right now.
Yeah, for sure.
And I like this because it's broad. It really covers anything to do with emotional or mental health. Just make sure you have other things in place to protect you no matter what you get.
I will tell people, you got to find the fun. What is it that fills your cup? Recovery is hard work. Your life cannot be all about this. Where's the fun? Well, how do you laugh? What makes you laugh? How do you go find the laughter and find the fun?
And this goes back to our other client who just loves that we're talking about them. But they found fun this week, a very unique kind of fun. And you and I were just saying, oh, thank goodness they're not sitting in a room with us for a minute. They're going out and having fun and living their life. And that's a beautiful little exposure, if you will.
Yeah, well, it motivates you to do the work. It goes back to those values and doing values-based activities. And if you're doing things that bring you pleasure and some sense of fulfillment and really speak to your values, you're going to be more motivated to do the things you don't want to do that are hard. Doing those things will allow you to do more of the things that you really enjoy.
That's it. And we're built as humans to want to be here and do well. It's built into our biology to want to sustain the species. So we should want pleasure and joy. That's a natural thing to want. For the clients you've worked with that have the most progress, what is something they are doing and that they've maybe asked themselves or that they bring to the table? Is there a couple common threads among them?
I mean, I think part of it is pushing them to do things that they don't want to do at times. I think sometimes we think about like being uncomfortable, but being uncomfortable is where we tend to grow. It's figuring out what is the appropriate risk to take in the moment.
Kind of trust the person or the setting they're in that it might be very uncomfortable and that's part of it.
So, look, I hate change, but I recognize that change is sometimes necessary and that I don't have to like it, but that I can work to accept it.
Yes.
That's kind of the motto for some of the work we do in this field too. You don't have to like it. You just have to accept that it's necessary and you're going to do it. Goes back to like that talking about myths too. That recovery means that somehow you have to like want to eat the food or that you're going to be this fabulous intuitive eater or that you have to like have a mindful meal all the time. I tell my patients all the time, I've hated breakfast since third grade when I realized that if I skipped breakfast, I could sleep 10 minutes later. As an eating disorder specialist, I still kind of hate breakfast because I get up in the morning and that's just not the way my brain works. I tell my patients all the time, I'm not hungry for breakfast. The truth is, I am hungry for breakfast. Of course, I'm hungry, but my brain is so focused on my to-do list that those voices in my head are so much louder that it drowns out my hunger cues. And if I don't eat breakfast, I'm going to want to gnaw my arm off before lunch comes. All of my patients who say, well, I'm not hungry, why should I eat? Well, I don't feel hungry either. It doesn't mean that I'm not hungry. And I don't have to love breakfast, but I know that I'm going to do it because I need to do it. I don't have to like it. I think sometimes people put too high of expectations on what it should be like.
That's a great myth buster, this idea that if I don't like it, I don't want it, I'm not motivated, is it going to work? And you're saying it has to, so you can't wait for that.
Right. One of the things that's changed in higher levels of care, we used to have this like, first you do the eating disorder treatment, then you do the trauma.
Yeah.
And because so many of our patients with eating disorders have both little t and big T traumas in their lives. And so it's a common co-occurring issue. And we used to think you have to do one and then do the other. But we know now cognitive processing therapy and EMDR, and we're integrating them more so that they're occurring simultaneously, that we're addressing both. But in a lot of trauma work, a lot of like exposure work, when we're talking about OCD, or we use the term like window of tolerance. We want to get them distressed enough so that change can take place, but we don't want to get them too distressed so that they're flooded and feel totally shut down. And I think maybe that's a good judge of therapy in general. Like, does your therapist, does your treatment program, do you feel that you are challenged enough to make progress without challenge so much that you feel emotionally flooded, overwhelmed, and unable to function?
That is excellent advice.
Knowing very well that therapists and treatment programs aren't perfect, and sometimes they're just going to step in it. Sometimes you are going to leave session feeling flooded or feeling overwhelmed and needing to ground. But in general, do you feel like the work you're being asked to do pushes you within your window of tolerance, pushes you to the point of you're not feeling super comfortable and this is difficult, but it's not so difficult that I can't work, can't function, can't think?
Yes. And that shouldn't be happening on a regular basis.
It's going to happen every once in a while, likely.
But if you're working together as a team, you need to know, just like you mentioned, what that window of tolerance is, and you have to honor it.
And if you go beyond that window of tolerance, that's good data. Like then your therapist or your treatment team should be like taking that data
Aha.
and coming back to you and being like, hey, we really pushed too hard. What is the data we got from this? How do we use that?
Yeah. What does that inform next time?
Yeah, what vulnerability factors weren't we taking into account that maybe you weren't ready to do this work today?
I hear a lot there in what you're saying, collaborating. There's a collaboration here, and I believe there must be, and it sounds like you do too.
You have to be. Yeah.
It has to be a team up. You mentioned EMDR. Do you like having those supplemental? I call them maybe alternative. I don't know that EMDR is alternative. Do you like the idea, or if you had success with clients going outside of the traditional therapeutic setting and getting these kind of approaches? Have they been helpful?
I have. I think back to my early training where the general rule was you shouldn't be working with two therapists.
How dare we?
As noted, you and I share someone that we work with. I actually have that experience with several of my patients, the trauma therapists that I collaborate with on several different patients that I really love doing the work together. Honestly, because we just offer different perspectives, I think it just provides this really nice balance. And she is an EMDR expert. And so she can offer this piece of it. Eating disorders are not her specialties. And of course, there's crossover. I'm really big on the idea of web of support. You've got this web of support where you're less likely to fall through the cracks.
And it makes us better.
It does. I think all of the time about a collaboration I had with a male therapist that we worked with someone together. And just by the very nature of I'm female and he's male, sometimes the person we shared would bring the same thing, supposed therapeutic no. And what was so amazing about it is she would bring it to him and offer one perspective, and then she'd bring it to me, and I come at it from a very different perspective. She could take those perspectives and meld them to figure out what she thought and what she felt. I am absolutely convinced that this lovely human being who had been through years of treatment and who had been through higher levels of care multiple times and she has a beautiful life and worked really hard to get there. But I do believe that part of what her treatment was that was so effective was having several different therapists, even if it's not the alternative therapies, equine therapy, EMDR, like TMS. It doesn't work for everyone, but there's different paths that can be really helpful.
Yeah. And it builds hope that if the sitting in a room with me, there's so much more, and then we can layer and we can add these other pieces.
Right.
I love the collaboration. I really echo what you said. Anytime I've worked with another provider, it's always enriched my practice as well as the client. And like you said, it's a team. It takes so much energy to work on eating disorders and the comorbidities. What a great thing to have.
Right. And especially when people have different specializations.
Yes. You mentioned trauma. I am so happy when someone else comes in and focuses on trauma and I can focus on eating disorders or I'm focusing on the anxiety. It just gives me more space with the client.
Right.
I like that. Is there a piece of advice that you would offer to someone on a recovery path or one piece you've already mentioned that you would highlight?
Well, I mean, I always go back to you got to feel the feels and eat the meals.
Yes.
Honestly, I think part of it is, and maybe we talked about this a little bit, the biggest gift that a treatment team can give to someone who's struggling is to be the holder of hope because recovery sucks. It's hard. And sometimes it's easy to lose hope. And I always tell my patients, when you lose hope, it's okay. I'm holding it for you until you're ready to take it back. Because we all need that, whether we have an eating disorder or not. We all need to figure out how in those dark times, how do we work to cultivate hope?
In disordered eating, hope can be a really distant, it's almost like part of that hijack. It just doesn't see it. It doesn't trust it. So that's a beautiful approach. I'll sometimes use the analogy that there is a black curtain and I promise you there's something on the other side. I know you can't see it, but I need you to trust me that it's there because I can see it.
Right. And that trust is so important because sometimes when you have an eating disorder, it's like standing in front of the funhouse mirrors that changes the way you look. And sometimes I'll say to people, like, you're not going to believe me. You see what you see. And it's trusting your team enough to believe that they see you more accurately in the moment than you're able to see yourself.
One of my favorite outcomes, I did a lot of interviews with some of my college age clients when they were going off and talking about their recovery. And the one thing that came up a lot was, I didn't believe you, but then it was true. And this idea of they thought I was completely ridiculous, but then they saw some of those truths later and it was so rewarding.
Yeah. Well, and I do a lot of work with people who struggle with both OCD and eating disorders. I always tell people if eating disorders and OCD were people, they'd both be assholes because they tend to attack people where they're feeling most vulnerable. It's like they play off people's vulnerability. And going to treatment requires you to expose that vulnerability and to really trust somebody else with that vulnerability. In doing this work, I never forget how courageous it is for people to reach out and ask for help and for people to be willing to hand off their vulnerabilities to someone else. And I think that's why it's so important for me as a therapist to remember my own fallibility. I need to pay attention to my own fallibility and vulnerability too.
Kind of like the radical openness where you work along with your own openness.
Yeah.
We work with some of the strongest, most resilient, tenacious, inspiring people. We're very fortunate.
Yeah. You get to work with some really incredible, amazing people. I feel very honored and privileged to be part of the journey of recovery for people.
And I'm glad you could bring some of that here today and what you've seen. That's inspiring to know you've walked the walk and seen people find what they came to you to find. Do you have one word that describes your intervention style? What I would expect from you if I was sitting across from you?
Nancy, that's where I want to cheat and ask our shared person.
We'll ask her later and then I'll add it as an amendment.
I love that. I'm sure she'd bring up the fact that I've occasionally therapeutically eye rolled her before. See this eye roll? This is my therapeutic eye roll.
You gave me the permission to do so as well. Oh, Anne does this, so I'm doing it.
Yeah, I acknowledge it. Here's my therapeutic eye roll. This is bull.
Well, sometimes I can't hide my face. I just can't. I can't not react to that statement. I'm not that good. I'm just not. You have filled this time with so much great information. I think a lot of people have benefited from you being willing to share what you know. And I so appreciate your time and coming here today.
Well, thank you so much for having me.
Thanks for listening to the Mental Health Spotlight podcast, helping you hold hope on your recovery path.